Now, we will start the first session with the title, Role of Early Screening, Differences Around the World. We kindly ask Professor Yasuhiro Kodera, the Chairman of Board of Directors in Japanese Gastric Cancer Association, and Dr. Daniel Katanachi, Associate Professor of the University of Chicago Medicine Center in US, to moderate the session. Please.
Thank you. It's a pleasure to be here chairing this first session, a very important session. And after a very touching introduction from families and patients, and of course, Debbie, who I knew well and miss dearly. This is a very important session because it's asking how can we improve early detection, which of course we know can have bigger impact in terms of cures if we can find the stage earlier. And so we have wonderful talks in terms of screening methods across the countries, Korea, Japan, and China. And I will take this opportunity to pass to my co-chair, Professor Yasuhiro Kodera from Nagoya University, to introduce each speaker.
Okay, thank you, Daniel. I think for the interest of time, we go straight on to the first speaker, Professor Kyu-Son Choi from Republic of Korea. She is a graduate of Dunduk Women's University, and after training at Yonsei University, her current position is Chief of Cancer Data Center, National Cancer Center. So, Dr. Choi, please.
Good morning. This is Kyu-Son Choi from National Cancer Center, Korea. It's my great honor to give a talk at the 2021 International Gastric Cancer Symposium. The title of my talk today is Gastric Cancer Screening in Korea, a Successful Story. And mainly, I would like to talk about the effectiveness of Korean National Cancer Screening Program in reducing gastric cancer mortality. This is the contents of my presentation. First, let me briefly introduce gastric cancer statistics and gastric cancer screening program, and then I will talk about the effectiveness of gastric cancer screening program in Korea and future issues. This figure shows global gastric cancer burden in 2020. As you can see, gastric cancer is the fifth most commonly diagnosed cancer, followed by breast, lung, colorectal, and prostate cancer, and both most common cause of death in worldwide. Although gastric cancer is the fifth ranked cancer worldwide, it is one of the most common cancers in Eastern Asian countries such as Korea, Japan, and China. And as you can see in the figure on the right, gastric cancer is the most common cancer in Korea. It accounts for 12% of total number of cancer cases in 2018. However, fortunately, gastric cancer incidence and mortality rates are gradually decreasing in Korea. As you can see in the figure on the left, the blue line for gastric cancer incidence is gradually decreasing in both men and women, and the mortality is also decreasing very sharply, as shown in the figure on the right. And we believe that this sharp decline will be associated with the screening program. In general, gastric cancer screening is not commonly recommended. However, Japan, which has a high incidence of gastric cancer, started a screening program for gastric cancer in 1960. And in 1983, it was expanded national screening program for people aged 40 or older, and photofluorography, so-called upper gastrointestinal series, was provided. Thereafter, several case control study and cohort study were conducted to evaluate the effectiveness of screening program, and a meta-analysis result reported that radiographic screening reduced the mortality of gastric cancer about 8% and 36% respectively. Then, based on these evidences, gastric cancer screening recommendation was published in 2008. According to this recommendation, photofluorography was recommended as a screening method. However, due to insufficient evidence, endoscopy test was not recommended. In Korea, a national cancer screening program for gastric cancer started in 2002. Endoscopy was introduced as a screening tool for the first time in the world. This is the screening program. It provides either upper GIS or endoscopy for men and women aged 40 or older by every 2 years. When endoscopy was introduced in the screening program in Korea, the evidence was very limited and there was a lot of controversy. However, since the introduction of gastric cancer screening in Korea, participation rate have improved significantly from 7% in 2002 to 52% in 2016. In addition, among screened, the people who underwent endoscopy increased significantly from 31% in 2002 to about 48% in 2016. So now only a small number of people were tested for upper GIS. In the meantime, endoscopy has shown significantly higher performance than upper GIS. The overall detection rate was 1.72 per thousand people, and endoscopy test showed more than 3 times higher detection rate than upper GIS. In addition, localized gastric cancer was more commonly detected in endoscopy screened group. And actually, people who had an endoscopy test were 2 times more likely to be diagnosed with localized cancer compared to never screened. If then, how effective is screening for gastric cancer in reducing mortality? We performed a nested case control study using Korean National Cancer Screening Program database, and this study result was published in Gastroenterology in 2017. In this study, we estimated the odds ratio of deaths from all cause and gastric cancer. And as you can see in this table, odds ratio of deaths from all cause and gastric cancer were 0.83 and 0.79 respectively, and it is statistically significant. This result indicate that gastric cancer screening reduced gastric cancer mortality by 21%, and this mortality reduction effect lasted until the age of 74. This table shows the odds ratio of death from all cause and gastric cancer by screening modality. And as you can see, endoscopy reduced the risk of gastric cancer death by 49%, while upper GIS reduced by 5%. This figure also shows that the risk of gastric cancer death is decreasing with the repeated examination. For example, those who underwent endoscopy screening more than 3 times have an 81% of mortality reduction. Even in the case of upper GIS, 21% mortality reduction was noted. In addition, as shown in the figure on the right, the effect of reducing mortality effect by endoscopy remained 48 months from the cancer diagnosis to the last screening. Based on this result, Korea gastric cancer screening guideline was revised in 2016. The biggest change from the previous guideline is that endoscopy test is recommended as the primary method, and upper GIS is recommended only for those who cannot undergo endoscopy. Also, upper age limit of the screening was set at 74. For those aged 75 to 84 years, there is no sufficient evidence to assess the balance of benefit and harms. And gastric cancer screening is not recommended for those aged 85 years or over. This is the Japanese gastric cancer screening recommendation. Japanese latest recommendation for gastric cancer screening has also been revised in 2018 to recommend endoscopy for both population-based and opportunistic screening. Finally, I have considered what is the most effective gastric cancer control strategy. According to the Cochrane systematic review, primary prevention by H.pylori eradication reduced gastric cancer incidence by 34%, and endoscopy screening in Korea achieved a 47% of reduction in gastric cancer mortality. Thus, a combination of primary and secondary prevention will significantly reduce the burden of gastric cancer, especially in high-risk population. On the other hand, upper GIS was not effective to reduce the gastric cancer mortality. Therefore, we are considering excluding upper GIS from the National Cancer Screening Program. And this is the summary of my presentation. In Korea, the nationwide organized gastric cancer screening program was launched in 2002, and National Gastric Cancer Screening Program via endoscopy achieves a 49% of mortality reduction in gastric cancer, while a 5% reduction in upper GIS. Even though effectiveness was reported, the benefit and harms of gastric cancer screening must be carefully considered before introducing population-based screening. In particular, as you know, endoscopy is a highly resource-intensive test and requires qualified physician. So careful consideration is needed, especially countries with low incidence of gastric cancer. So this is the end of my presentation. Thank you for your attention.
Thank you very much, Dr. Choi, for your very nice presentation. And obviously, indeed, it was a successful story in Korea, probably because you jumped straight to endoscopy. Very clever. And now, I'm sorry, we like to welcome the questions later, and we go straight to the next presentation by Dr. Nobutake Yamamichi, who represents Japan. He is now director at Center of Epidemiology and Preventive Medicine at the University of Tokyo. So Dr. Yamamichi, please start your talk about gastric cancer screening in Japan.
I am Nobutake Yamamichi from the University of Tokyo in Japan. I present gastric cancer screening in Japan. I have no slides concerning this presentation. At first, I will show you the mortality and incidence of gastric cancer in Japan. The population of Japan is about 130 million people. Concerning the mortality, about 42,000 people die of gastric cancer every year. Concerning the incidence, about 130,000 people develop gastric cancer every year. Although the mortality and incidence of gastric cancer has been gradually decreasing nationwide, it is still the second common malignancy and the third leading cause of cancer deaths in Japan. This slide shows the history of population-based gastric cancer screening in Japan. Screening of gastric cancer in Japan started in 1960s. At that time, gastric cancer was the most severe health problem in Japan. About 0.2% of the Japanese people died of gastric cancer per year. Since then, for more than 50 years, X-ray based gastric cancer screening was the only officially approved method of gastric cancer screening. In 2016, endoscopy was finally approved as a recommended method for organized gastric cancer screening in Japan. However, actually, endoscopy-based gastric cancer screening started at the 1980s as opportunistic gastric cancer screening, and it has been widely used for more than 30 years. It is well established that H. pylori infection is a definitive risk factor of gastric cancer. This is a result of Uemura's classic study, which reported the prospective observation of endoscopy examinees. During the 8-year observation, gastric cancer occurred in only the subjects infected by H. pylori. This is the result of Foucault's famous work, which showed the effectiveness of eradication therapy to reduce the gastric cancer risk. This shows that eradication of H. pylori should be a promising clinical strategy against gastric cancer. Unfortunately, however, eradication cannot completely suppress the oncogenic potential of the stomach, which is already damaged by chronic inflammation of H. pylori. This slide shows the prevalence of H. pylori infection in the world. Although it is known that prevalence of H. pylori has been gradually decreasing worldwide, the infection rate of H. pylori is still quite high, especially in developed countries. And of course, in the East Asian countries, the infection rate of H. pylori is also known to be quite high. In Japan, the prevalence of H. pylori has been rapidly decreasing for these 30 years. Our large-scale cohort data from generally healthy people show that the prevalence of H. pylori has obviously decreased in Japan. Our data showed in 1996 the infection rate was about 50%, but it decreased to about 31% during only the 14 years. This is the main route of gastric tumorigenesis. It is well known that long-term gastric inflammation due to chronic inflammation of H. pylori is the most severe risk of gastric cancer. In Japan, reduced prevalence of H. pylori infection has changed the strategy against gastric cancer. Namely, reduced infection rate of H. pylori has made it possible to classify the risk of gastric cancer based on its infection status, current infection, past infection, and non-infection. Serum-based screening is not officially approved as a population-based screening, but it is widely used as the opportunistic screening. Among various methods, the combination of serum anti-H. pylori IgG and pepsinogen test is most frequently used in Japan. The subject can be classified into Group A, HP IgG negative and PG test negative, Group B, HP IgG positive and PG test negative, Group C, HP IgG positive and also PG test positive, and Group D, HP IgG negative but PG test positive. Many studies show that gastric cancer risk increases from Group A to Group D in proportion to the severity of H. pylori-induced chronic gastritis. In the left panel, Yamaji reported a significant association between the cancer detection and the ABCD risk classification using the large-scale data of generally healthy people. In the right panel, Ohata shows a significant association of ABCD risk classification and gastric cancer development using the prospective cohort data in Japan. About endoscopy-based screening, Kyoto Classification was recently proposed in 2014, and it has been gradually spread in Japan. This classification focuses on the 19 characters of gastric mucosa by endoscopy, which can predict the infection status of H. pylori. Nowadays, upper GI screening by endoscopy is expected not only to detect gastric tumors, but also to evaluate the infection status of H. pylori. In other words, risk prediction of gastric cancer by endoscopy is eagerly expected today. Among many endoscopic features of gastric mucosa, atrophy is the most famous and useful one, reflecting the current or past infection of H. pylori. Especially, Kimura-Takemoto classification to assess mucosal atrophy is very widely used in Japan. Our prospective 7-year follow-up study of generally healthy people clearly showed that atrophy diagnosed by endoscopy is useful to predict the risk of gastric cancer development. Similar to endoscopy-based screening, evaluation of gastric mucosa is also expected in X-ray-based gastric cancer screening. Mucosal atrophy and enlarged folds by barium X-ray are considered as the two major features to reflect the infection of H. pylori. Our prospective 7-year follow-up study of generally healthy people again clearly showed that atrophy and enlarged folds diagnosed by barium X-ray are both useful to predict the risk of gastric cancer development. This is the last slide of my presentation. In conclusion, although the mortality and incidence of gastric cancer is decreasing nationwide, it is still the second common malignancy and the third leading cause of cancer death in Japan. At present, only barium X-ray and upper GI endoscopy are the officially recommended methods for population-based gastric cancer screening in Japan. Infection of H. pylori is a definitive risk factor for gastric cancer. The prevalence of H. pylori infection has been obviously decreasing, not only in Japan, but worldwide. Reduced infection rate of H. pylori has changed the strategy against gastric cancer in Japan. The concept of stratifying the risk of gastric cancer based on the infection status of H. pylori, current infection, past infection, and non-V infection has been widely spread in Japan. Thanks for your attention.
Okay, thank you very much, Dr. Yamamichi, for your very nice talk. And we know that after your talk, that endoscopy has been performed not only to detect gastric cancer, but also for risk evaluation. It's very interesting. So our next speaker is going to be Dr. Wu Qi, who represents China. And among many roles he plays in China, he is currently a director of Peking University Cancer Hospital Endoscopy Center. So Dr. Qi, please start your talk.
Good morning, everyone. I'm Dr. Uchi from Peking University Cancer Hospital Endoscopy Center. Thanks for the invitation of the Congress and thanks for the introduced by the chairman. Today, I want to talk the topic earlier screening for gastric cancer in China. I will introduce this topic with following three aspects. Firstly, the epidemiology in China. As we know, the age standardized incidence rate for gastric cancer is highest in Eastern Asia with 32.5 per 100,000 in male and 13.2 in female. In China, the date is even higher. It's 47.4 in male and 15.8 in female. Besides, despite a rapid growth from 1970s to 1990s, in the past 30 years, burden of gastric cancer mortality slowly declined in China. However, almost half of its estimated deaths from gastric cancer occurred in China. There are two distinct features of gastric cancer. Firstly, the incidence of gastric cancer in urban areas have been far below the level in rural areas. Second, there is substantial geographic variation in mortality within the country. However, with the elevated rate was seen in the northern and central province in China. As we all know, China is a quite large country. We must face to the main challenges in reducing mortality and morbidity of gastric cancer. The first one is a large and aging population. The second is regional difference in mortality and morbidity. The third is insufficient public awareness of earlier screening. The second part, I will put emphasis on how we act to determine etiological factor and preventing methods of gastric cancer in China. Over more than 30 years ago, epidemiologists from our hospital launched a series of programming to elucidate risk factor and effective intervention method of gastric cancer. Linqu, the annual age-adjusted mortality were 70 per 100,000 among males and 25 among females, nearly double level of the national. During that time, there had been no clear evidence between the occurrence of gastric cancer and HPV infection. In the first phase from 1989 to 1994, a study involving around 2,060 adults revealed that over 77% residency in Linqu County had been infected by HPV. Prospective studies have demonstrated an 80% increased risk of developing dysplasia or gastric cancer in those infected with HPV. Then, in the second phase, a target study on etiological intervention in high incidence area of gastric cancer was set up in 1995, and after 15 years follow-up, eradication of HP were confirmed to reduce 39% risk of gastric cancer. In addition, even for old adults and people with precancerous conditions, gastric cancer risk can still be reduced by eradication HPE. One extended follow-up period to 22 years, we also noticed that eradication of HPE can not only reduce the incidence rate of gastric cancer, but also significantly reduce the mortality of gastric cancer. Then, these findings serve as very important indications for WTO to develop HPE education strengths for preventing gastric cancer. Professor Yu in our hospital was invited to participate in development of this guideline. And from 2009 to now, we began a new intervention trial in Linqi country. The trial will promote a more solid data to evaluate the full range of benefit and adverse consequences of strain for gastric cancer prevention by eradication of H.pylori. The final results will be uncovered in near future. In the last section, I will briefly introduce the current applied earlier screening strategy of gastric cancer in China. Except in areas with high incidence of gastric cancer, the proportion of HPE positive population is too large to routinely screen. Besides, no HPE related gastric cancer may be missed. Thus, in the new guideline, in addition to HPE detection, international experience have been taken into. For example, no invasive serological screening, especially PG method, has the advantage of high efficiency, low cost, good compliance, and simple operation, and can be used in a large-scale screening. Now, it has been widely used in screening of gastric cancer and precancerous lesions in many countries, like Japan, South Korea, Finland, Norway, and other countries. So now two-step procedures including general pre-screening by serological screening and diagnostic screening by gastroscope is widely accepted in China. In the guideline, high-risk population was identified as over 40 years old and with one of the following situations such as HPE infection, family history, and others. Then, a serological measurement contained PG1, PG2, G70, and HPE detection will be recommended. People with abnormal serological results were further subjected to standardized gastroscope screening. As we know, this step can improve the detection rate of early gastric cancer, but will no more reduce the incidence rate of gastric cancer. Here, I want to thank for the Japanese endoscopists. Many of them help the Chinese doctors hand by hand. In summary, the key to earlier screening of gastric cancer is active prevention and intervention, thus optimizing and standardizing detection objects and methods will help strengthen the earlier screening population more accurate. At last but not least, the training of professional technicians as well as multidisciplinary discussion with academic research will contribute to the further development of gastric cancer screening in China. Thank you.
Thank you very much, Dr. Chi, for your very comprehensive talk, and we do find some difficulties in such a big country, which is different from Korea or perhaps Japan. Anyway, thank you very much. So now I'm going to pass this discussion on to Professor Katenachi.
Thank you. And we have just a few more minutes, and we wanted to make sure that we had some of the panelists to comment. The first, maybe we'll have patient panelist, Ms. Hiromi Todoroki, provide some comments on what we heard here, and then we'll move to Dr. Ryu also to see what insights she might provide.
Thank you. And thank you for giving me such a great opportunity. I am Hiromi Todoroki. I am chairwoman of non-profit organization for gastric cancer patients. I think understanding the correct meaning of screening examination is the key for us all. I lost my husband due to stomach cancer. He underwent screening examination every year. He had family histories of stomach cancer. His cancer was detected in an advanced stage. Screening aims to detect disease in its early stage among healthy people. However, some people undergo screening when they feel unwell. There are many over-the-counter drugs for the stomach. Busy workers tend to take these drugs. Of course, if feeling unwell, we should go to see a doctor right away. I think this is a misunderstanding that we must face. In Japan, stomach cancer screening is recommended for healthy adults 50 years of age. I think people who have family histories may have higher risks. Those people may need gastric cancer screening in a proper way, even in their young ages. I expect research of liquid biopsy. I hope this technique will help early detection. Elimination of Helicobacter pylori will prevent stomach cancer. After elimination, some people do not feel the need for screening examination. I believe correct information is the most important to help our health. So, I am working with the hope that early detection and treatment of stomach cancer will make further progress. Thank you for your time. I really appreciate it. Thank you.
Thank you so much for those wonderful comments. Maybe Professor Ryu, would you have some comments directly to those statements and also to the previous three presentations?
Hi, I'm Kyoto Ryu from National Cancer Center, Korea. Well, Korea, Japan have the organized screening program for gastric cancer, but in other countries, they doesn't have organized screening program. So several screening approaches may be proposed, like pepsinogen and H.pylori antibody test, but it is not that sufficient. We don't have sufficient data for that, for screening tools. So maybe we need to have more studies to develop other good gastric cancer markers for other countries.
Wonderful, thank you. You know, we don't have a lot of time, and I have many questions that came in, and even some of my own, but one of the common questions was, maybe we can have the panelists, each of the speakers, briefly comment. How did this pandemic with COVID-19 affect your ability to screen in this past year? And if you think it negatively affected our ability to do so, do you think we're going to see repercussions of this in the next years to come with more advanced disease presentation? Maybe we'll start with Dr. Choi.
Nowadays, the COVID-19 is the worldwide health issues, not only in Korea, but also in other countries. So due to the COVID-19, last year, the stomach cancer screening rate is decreasing compared to the previous years. So now we are trying to promote screening rate because COVID-19 is not actually closely related with the cancer incidence actually. So we are trying to promote screening rate in Korea.
Great. How about Dr. Yamamichi?
COVID-19 pandemic was a very severe problem last year in Japan, and in Japan, in many large cities, about 1 or 2 months screening was completely stopped. But after that, we could overcome many problems about COVID-19. And we started gastric cancer screening using endoscopy or barium X-ray. And fortunately, there have been so severe problems about infection. And we mostly can do screening safely in Japan.
Professor
Great.
Katenachi, let
Yes.
me add one comment here. Yes, certainly COVID did not affect the instance, but because of this pandemic, all general people didn't go to a screening, or even they had symptom, pain, but couldn't go to the hospital.
Right. This was the question I was asking.
So
yeah.
as I'm the general director of Seoul National University Cancer Hospital, we actually look at the changing of the stage of before or after. And we certainly noticed that patients have a more advanced stage. So this is a message of, yes, screening is important.
Absolutely. Absolutely. Well, I think we've gone over, and so I think we'll have to close the session here. And thank you so much to all the speakers for wonderful presentations, for panelists, Ms. Todoroki, and also gastroenterologist Professor Ryu. Thank you very much, and to my co-chair Yoshihiro Kodira.
Thank you.
Thank you.